Good morning from New York. Cardiac catheterization laboratories of Mount Sinai Hospital. George Dangas and Dr. Vishal Kapoor are moderators today. Good morning.
Morning. Good morning, Dr. Angus.
Welcome, Vishal. This is going to be a great case, I think. But before we jump into the case, let me just take the opportunity to say that this is the last webcast of 2014. We wish happy holidays and a happy new year to everyone who is attending. And we're going to see you next time here on January 28 for the first webcast of 2015 on endovascular peripheral vascular cases. As you know, in setting up this case, we have the website. You can see the questions and a button to submit them, or you can just send us a question at info@peripheralvascularinterventions.org, peripheralinterventions.org, www.peripheralinterventions.org. Click on the button or send us an email at info@peripheralinterventions.org. Also remember that 2015 is coming up, June 17 to 19. We have on site here at Mount Sinai the Cardiovascular Symposium of Complex Coronary Valve and Vascular Cases, and you should put that in your calendar and try to attend. Both of us will be here, and everybody else from the cath lab, Dr. Krishnan, Dr. Sharma, and everybody else will be here in person, and glad to meet you and showcases kind of in a very close up. As you know, every case we show in the webcast, it's also archived afterwards in the website, and you can view it. Same as this case, after its completion, if you miss any portions or if you want to send us a question later on, you could access the full webcast at the website, and you can send us a question later, and we put our answers up in the blog. Welcome, Vishal, and let's go to the cath lab team to get Dr. Krishnan, and back by popular demand, Dr. Karthik Guja, who will tell us a very complex popliteal case.
Well, welcome, George, and thank you for the nice introduction. It's nice to be back, and as Dr. Dangas said, happy holidays to all. Dr. Guja is back from India. We're glad to have him. Dr. Wiley is in the back for moral support today, he told us. And, Dr. Ray Lascano, we have Elizabeth Holton and Ricardo to help us, along with our wonderful AV team. We have a really exemplary case here, Dr. Dangas and Dr. Kapoor. As you know, we've tried to show, all the different types of cases that people will encounter in endovascular intervention. And this is a case that's probably one of the more challenging ones, as all of you know, who do this quite a bit. This is a case of a popliteal occlusion. So before I go to the angiographic anatomy, I'm going to ask our fellow, Dr. Bhaskar Purushottam, to go ahead and present the case. Bhaskar?
Good morning. So today we have a 68-year-old woman with lifestyle-limiting right lower extremity claudication with Rutherford stage 3. She's continuing to have these symptoms despite exercise and silastazole therapy, and her initial diagnostic ABIs were significant at 0.7. She has a history significant with known PAD. We recently had a left popliteal intervention. There's diabetes and hypertension. Medication, she's on aspirin, silastazole, lisinopril, atenolol, and chlorthalidone combination, and metformin. She is a ex-smoker, and the rest of the history was not significant. So her vital signs, as you see, are pretty stable, and physical examination, apart from poor pedal pulses, there was nothing else significant. And she recently underwent a left popliteal CTO intervention with DCB treatment, and the current plan is, as Dr. Krishnan was saying, to go after the right popliteal CTO.
Thank you so much, Bhaskar. Now I'm going to ask Dr. Guja to go over the angiographic anatomy. Karthik?
Karthik, speak a little more loudly.
So we did the contralateral axis, and we crossed over as we normally do to any of the lower extremity interventions. This is the ipsilateral CTO, the right-sided runoff. We took a picture of the popliteal CTO. You can see the distal SFA. And this is a picture where you see that exactly right at the proximal popliteal there is a CTO which starts and reconstitutes in the mid to distal popliteal. Recently long CTO. Again, it's a popliteal CTO, and so it becomes a little more complex. And to the runoff, you can see here the AT is patent and the peroneal is patent. You can see the posterior tibial is occluded. So we took different angles as we normally do for any popliteal CTO. We take different angles and we take orthogonal angles for every CTO. And you can see here that it's a proximal popliteal CTO, distally reconstitutes. We took an orthogonal shot just to see if we have any collaterals coming right out of the CTO so that not to injure those collaterals. And we always take a runoff before we do any CTO. And this is a runoff showing that it's an AT, patent AD, and the peroneal reconstitutes the posterior tibial, and you can get a good plantar arch right here.
Thank you so much, Karthik. George, our plan is going to be to cross this with the standard wire technique. So before I go ahead and let me just give you our plan, and as I start working with Dr. Guja, I'm going to have Dr. Wiley and yourself and Dr. Kapoor talk about some of the challenges of popliteal CTOs. So our plan here was very simple. We decided to use a standard wire technique. We were going to use an escalating wire technique to borrow from the coronary terminology. We used an angle catheter, I know which Dr. Wiley will talk about, and in this case we took an aqua tempo vert tip catheter, and then we went with a Confianza Pro wire, Pro 12 wire, which is a high grade, a high tip wire for the coronaries, and we're going to start crossing this. Just 2 important points. We did it on roadmap, so we basically have, like Dr. Guja said, orthogonal views, and I'm going to start working, and Jose, maybe you can, are you mic'd? Oh, good, Jose's mic'd. I just want to make sure that Dr. Wiley and you talk about some of the challenges that we face while we work. So if you guys can show fluoro as they talk. Thank you.
Yeah, one comment I have to make is that as you saw, the orthogonal views are very important. In the RAO coda, in the RAO, the proximal cap was seen very nicely, and the LAO, the distal cap was seen very nicely. So I think that's a key point to set up the views nicely, and indeed they are working on the RAO to start crossing the proximal cap. Vishal, any comment?
No, I think you're absolutely correct. I mean, we have to take both views to really define our entry point and then the distal anastomosis. And in this case, the RAO is very suitable for us to go forward with. So I think that's the best way to approach in this case, and then take it from there as and how we cross the lesion.
George, as you see, one of the challenges here is that there's a very large collateral, so preferentially the wire and the catheter, we want to go into that collateral.
A little more?
So I'm assuming that Dr. Cushing is trying to get his vert tip catheter close to the very tiny beak that you see there and try to traverse that chronic occlusion.
I think once he embedded the catheter right into the stump, the wire went a little bit more ahead.
So you can see here, guys, as you guys talked about, the collaterals are clearly a problem. So now we're just trying to advance this, and you can see here that I'm going to advance the catheter. Advance the catheter, Ray. We're going to advance the catheter into the occlusion here.
I think probably may be helpful now to go to LAO. That shows better the distal target.
Okay, we'll do that now. Hold on a second.
Yeah. Jose, any other ideas about what, if he hadn't chosen this catheter wire combination, what else could we choose?
I think he's doing quite well. I think he has a 014 wire, correct, Dr. Cushing?
I did. I went with an 014 here. I went with an 014 Confianza Pro. And you know, I think all of us here pretty much follow the same technique. It's an escalating wire technique that we use, and you can see in 2 views, we're in a very good position, I think, heading towards.
Right.
I know that Ray is a little, doesn't want to advance this a little bit, but see right there, the movement of the wire is incredibly important for all those who are doing this, I would advance the wire, the catheter here, Ray, if you can. Are you having a lot of trouble?
So, Dr. Krishnan,
There it goes. You got a little more? Okay, good. Let's stop there. Yes, go ahead.
So what is your algorithm for the escalating wire technique? I mean, in this case, you're doing great, so I don't think you have to step up your game. But if Confianza didn't work, what's your next wire of choice?
Well, the interesting thing is, I know that Jose can also talk about this. We generally don't like using 035 wires below the knee or at this level. I just, I'm a little concerned here, as Dr. Guja was commenting to me in my ear, that we're a little bit off, which is okay. So I'm going to stop here and have
We may be a little bit off, but we don't know. We'll do another roadmap because there's a lot of movement in the previous roadmap.
Yep, you got it. I see. Oops.
Well,
Okay,
the other
let's stop
thing
there.
is crossing the devices such as vials and the devices as such that may be helpful and direct you into the true lumen. It seems that, yeah, you might be a little off there.
Okay, let me pull this back a little bit. Okay, let's go roadmap again.
So Dr. Wiley, would you start with like a try with a crossing device of any kind?
You know, I'll try a little more with the 014 wire, and if that doesn't work, perhaps a device, a crossing device such as a vice, may be an alternative. Yes, I think he's still going on the right
Yes.
track, so I would try a little more with this approach.
Vishal, the problem is using a crossing device initially in popliteal is if you get into a dissection plane, you'll end up being in a dissection plane, and if you're in dissection plane, then you'll end up stenting it. That's why I think Dr. Krishnan is primarily trying a wire, because you're more of being intraluminal, more with the wire, because your channels are bigger. So, and you'll be able to easily do
There we go.
There
atherectomy
it
and
is.
avoid stenting. So clearly you see that we get the microchannels better with the wires.
Yeah, I agree. I think it's just a lot of patience. And you can see here, now we're through, and now Ray's going to advance, and I'm just going to rail the wire for him, and it's going to come back, as always, as you know. Live cases, Ray, you got to twist the catheter. One of the things we're talking about here is twisting the catheter to help Ray get the catheter towards. Careful, you're going to kick the sheath out, so be careful. So remember, all of you at home, as all of us here know very well, when you're pushing here, you may actually kick the sheath out up top. So what we may do here, like Dr. Guja is already starting to do, is get the 018 Quick Cross or Trailblazer or whatever type of catheter that you have available and advance, and then we may actually, you know what, give me an 035, guys. Give me an 035 Trailblazer, it'll go here. We'll go with an 035 Trailblazer. Actually, you know what? We'll go, Dr. Guja just talked me into it. We're gonna go with an 018. So now that I think we're across, let's not get too cocky. I think we're across. Dr. Dangas, Dr. Wiley, Dr. Kapoor, and Dr. Guja, how would you tackle this lesion? You know, for those of them at home, you know, this is, let me just set that up by one situation. As we know traditionally, and I do mean traditionally, this has been a no stent zone, right? No stent zone for multiple reasons that Dr. Bhaskar is going to go over. So I'm just curious, since all of you have been doing endovascular intervention for a long time, what had you done in the past, and what are your choices for treatment at this current time? And I'll start with Dr. Dangas first.
Yeah, I think clearly we, you know, this in general, regardless of the chronic occlusion, this is a great anatomic area for atherectomy.
Perfect.
And the occlusion makes things a little bit more difficult. So a balloon, a cutting balloon or a drug-eluting balloon, drug-coated balloon could be a good choice. Provided that there's not an extensive dissection, we may be happy with that result. This is absolutely a bending area of the artery, so a stent, sort of perhaps the newly devised Supera may be an option, but again, that's a bare metal stent. We may run into problems or not. I think the first time around we try without the stent if we get a good result without the dissection. Vishal, what do you think?
No, I agree. I mean, we were intraluminal, and especially with the popliteal region, you want to avoid the stent strategy and try to see if you can get away with atherectomy and balloon. And if there is a lot of dissection or flow-limiting dissection, I would say we'll probably choose Supera as one of the options. I'm sure Bhaskar is going to discuss the data behind Supera and popliteal and how it goes, but I think that's another viable option after ballooning and atherectomy.
So what wire are you using now? You put the V18 wire down there,
We
or
put a Grand Slam wire.
Grand Slam, 014 Grand Slam?
So now, Jose, what would you do? What have you done in the past before the era of DCB and Supera? And what have you done? And how has that changed with the advent of DCB and Supera, if it has changed?
Well, first of all, it's important how you cross this lesion. If you thought that there was a subintimal dissection, then I would not use atherectomy. I would just do a balloon angioplasty, and if the result is optimum, I will stop there. If I'm sure that I went intraluminal, as it appears to be in this case, I would consider using atherectomy. The data is somewhat compelling with the definitive LE trial that the patency is reasonable. Before we perhaps used to do atherectomy or balloon alone, I would not use a
Listen,
tubular
Mejor.
slotted stent in this area because of the deflection of the knee. But now with the new technology that we have available, I think we have to decide if we will use a drug-eluting balloon or we will use a interwoven nitinol stent such as the Supera.
Can you talk a little bit about the differences in the stents, Jose?
Yeah, well, the interwoven nitinol stent has the feasibility that has much higher radial strength. And
Is it radial strength or is it non-compressibility?
I guess it's the same
It's
thing.
not, I don't believe it's the same thing though.
I basically
why.
think is calling the same thing in a different way. Basically, what you're preventing is the crimping of that stent, whether you want to call that you have strength opposing against the wall or you're preventing the stent from crimping. I think we're calling the same thing in a different way.
Well, you know, I got to tell you, just to talk here, I think that's a little yes and no. The reason is we know that restenosis may be aggravated by the activation of the stretch receptors from the outward force of standard nitinol stents. The idea of the vascular mimetic Supera is that it doesn't necessarily exert an outward force, it just resists compression. So therefore, the sizing of the Supera becomes very important, and we'll talk a little bit about that in a second. So that's just my point. I think that a lot of people are a little confused on radial strength versus non-compressibility.
You know, I think nobody really knows exactly what is the mechanism that's causing this, but probably restenosis because of the injury that you create before.
Yes.
Before you even put your stent, when you balloon, when you do atherectomy, it causes an inflammatory response. So,
Sure.
So I think the question here is whether in a case like this you would use a drug-eluting balloon or whether you would use one of these interwoven nitinol stents.
Well, you know what? I we're lucky because we have George here, who's obviously world famous in IVUS. George, we've dropped a IVUS catheter in.
Great.
We're gonna pull back and let you let us know how you think we crossed this lesion. Floor, guys, just to show. I'm gonna pull back, George. We're obviously in the tibial here.
Yeah, you see other vessels around, which are, not a dissection, just a different vessel at 9 o'clock. So there's some plaque there in between 6 and 9 o'clock.
Is that an artifact, George, or plaque?
It's an artifact.
That might be artifact, right?
It has never stayed, it has never moved, so it's kind of an artifact,
So here we are in the occlusion now, George.
right? It looks like we're in the true lumen so
Right?
far.
So far.
And so far, again, in the true lumen, there's a lot of plaque around. There's a lot of plaque around again, concentric, eccentric plaque.
There it is.
Yeah, and let me see, it's 1, 2, 3, 4, 5. Is a 5-0 vessel, media to media.
And now we're back in the true lumen. So you think it's a luminal cross here?
I think it's a luminal cross.
Okay, great.
And the vessel diameter seems to be around 5.
All right, great. So I'm going to just go ahead and come to a consensus because we're all lucky here. We have each other to run things by. So I was thinking about here, since we're in a luminal cross here, George, I was going to do an atherectomy followed by a DCB. I could be talked into doing a DCB followed by a Supera, and I could also be talked into doing just a DCB alone. So before we get to that, since we have time, I'm going to stop the case here, check an ACT. I'm going to have Dr. Bhaskar go over what's the pertinent data, and then we'll come back and talk about it. Dr. Bhaskar?
Yeah, hello again. So we're just going to briefly review what is relevant to our case, and so it's going to be upon popliteal artery interventions. So some of the key points to be considered, which some of the points were already touched upon, was A, it's considered a no stent zone. It's considered as a landing zone for surgical bypasses. There's a significant flexion hinge point, and then it forms a conduit between the large SFA and the small infrapopliteal vessels, and several geniculate branches arise from the popliteal region. And then also with calcification and highly variable anatomy, makes it all a complex artery to treat with. So here's an example as the team was talking about using different kinds of stents and what is the best. So if you look at the angiogram on panel A, which is on the left hand side, you see there is a diffusely diseased, and angiographically it looks pretty bad, but the gradients are not too bad. But then with the knee inflection, you see the gradients build up at 2 points at the hinge point, which is right at the bottom, and then right at the mid zone is near the adductor canal. and then you implant the first stent in the proximal portion. The gradient drops down to 0, and again the gradient down below 0, but this is the knee in extension. Now with the stent in place in D, and you bend, you see the gradient builds up, and when you deploy the next stent, that's when you see the gradient completely disappears. So essentially what this tells you is this popliteal artery is a very dynamic vessel. It's not static vessel, and therefore should be treated and approached very differently. So these some of the non-stenting endovascular approaches which they already discussed about. So I'm going to start off by talking about the definitive LE study. So this is one of the largest independently adjudicated study of peripheral atherectomy. And to summarize the 12-month results, essentially they show that they were safe and effective, and that they were pretty good for short, medium, long lesions in claudicants as well as CLI patients. And if you notice that in the SFA and the infrapopliteal, which also had a decent proportion of popliteal lesions, that they had a very good patency. The complications were not too bad. The distal embolization was around 1.6%, and interventions required for complications was around 7.6%. But I think some of the key highlights of the study was especially its benefits seen in diabetic claudicants. So they had 800 subjects enrolled across in 47 centers, and they had the standard statistical power study done to make sure that they could judge the results between diabetic and non-diabetic. So these were some of the standard key inclusion and exclusion criteria, and in the interest of time I'm just going to go ahead. So these are the results. On the left hand side, if you see the bar graphs, the results between the diabetics and the non-diabetics with regards to the 12-month primary patency was pretty good, but if you go down below with the bare metal stent, it's pretty bad with the diabetics, and similarly with the standard alone balloon angioplasty.
Oscar? Yeah,
Yes.
I just want to stop you there because I don't want you to gloss over that. I think this is one of the, I know it wasn't a randomized controlled trial, but clearly a large core lab adjudicated study. This was probably one of the first, actually the only peripheral arterial intervention atherectomy trial that we know of where there's absolutely really no difference between diabetics and non-diabetics. In the DCBs, we've seen benefit in the diabetics over the non-diabetics as compared to PTA, but in this, it's very important to point out that in such a large randomized, core lab adjudicated, registry of sorts, clearly you saw no difference. So don't gloss over that one. That's a very important point.
Thank you, Dr. Krishnan. And then on the right-hand side, you can see again that across different lesion lengths between diabetics and non-diabetics, the primary patency was pretty comparable at 12 months. And once again, this was not seen with some of the other modalities used. So here are the results across different segments treated. And if you see in the popliteal segments, they have a good patency rate from 65 to almost 85% depending on the lesion length. And then this is the impact on the CLI.
Bhaskar, can you go back and go over the popliteal specifically on that?
Yeah, so
on the different lesion lengths.
Yeah, so when you look at the some more simple lesions where it's like less than 4 centimeters in length, you notice that there is a primary patency almost approaching 85%. And these primary patencies were assessed by duplex ultrasound by looking at the velocities. So if it was less than 2.4, which means that the stenosis was not too bad, presumably less than 50% binary stenosis. Now when you go from 4 to 9 centimeters, obviously the primary patency drops down and it goes down to 75%. And once it goes 10 and above, then it really starts to drop down to 65%. But still, I know historically it's not been very good, but I think this atherectomy study, especially with popliteal lesions, definitely is quite promising. You want to add anything to that, Dr. Krishnan?
I think it's important to point out, I know Dr. Wiley's looking at it closely, is the mean lesion lengths. If you see the primary patency rates on the less than 4 and very short lesion lengths of 2.2 shows that you do have a patency rate that's very acceptable. As the lesion length increases, the mean lesion length increases to 6.5, which again in the popliteal is a very challenging anatomy and a reasonable lesion length. The one we're dealing with right now is about 6 centimeters. You're talking about a 75.4% 4% primary patency as suggested by duplex. And 10 plus, obviously, I think everybody would accept is a very complex lesion, and you're going to expect lower patencies. So in this particular type of lesion that we're dealing with, it's obviously a very favorable, and we have data to show it's anatomically favorable for atherectomy. I'm not saying we're doing it, I'm just generally saying it's favorable for atherectomy. Go on.
And then if you look at the impact of the definitive LE study on the CLI patients, I mean the dark blue one is the one with the atherectomy, and when they compare it with the stenting and also with the bypass studies, clearly you can see the patency rates where the limb salvage and the wound healing rates were pretty impressive with the atherectomy arm. And then this is a comparison. I mean, you cannot compare apples to oranges, but just gives you a rough perspective that patients who were treated with atherectomy, especially with the Silverhawk and the Claudicants, they have pretty good 12-month primary patency when compared with the others. And this is also a similar slide, again, looking at all the other atherectomy devices with lesion lengths of 7.5 centimeters. The atherectomy def by the Silverhawk did pretty well compared to the others. And then I would like to switch gears and talk about the drug-coated balloons. And we know that with the drug-coated balloons recently approved for femoropopliteal lesions, this has opened up a whole new era. And this was the study from the Lutonix, that is the LEVIN-2, and they found that they had pretty comparable target lesion revascularization or freedom from it when compared to the other stents. And so this is the LEVIN-2 trial. Essentially, it was a randomized study where the 2:1, and they had a 12-month follow-up on these patients. The control arm was just dilatation with the standard balloon angioplasty. So these were some of the angiographic characteristics. If you notice that the standalone balloon angioplasty had a higher rate of bailout stenting and also a higher rate of dissection, which was statistically significant. And you can see a decent proportion of these patients had calcification as well as total occlusion, which was similar to what we have in our case. So this was the safety data. So the freedom from any primary safety event was pretty much comparable between the two groups. And I'm sorry, the numbers don't highlight well, but the P was not significant. It was 0.1. And then this is the primary patency, the efficacy rate. Clearly there was a significant improvement with the use of a drug-coated balloon by an improvement of almost 30%, and the P was pretty significant. And then this is the freedom from TLR, which clearly shows the Lutonix was marginally better than the standalone balloon angioplasty. So to summarize, essentially, it was considered non-inferiority with regards to safety to PTA, very low rate of embolic events and reinterventions. And based on the LEVIN-2 and the continued access registry, so far they haven't reported any rare adverse events. Correction, no adverse events. And the efficacy at 12 months, as I showed you earlier, there was a 30% improvement in the primary patency. Therefore, the clinical benefit is target lesion revascularization, freedom from it, almost approaching 90%, continued improvement in the Rutherford class, as well as the walking distance.
Oscar, if I could just make a couple of comments on the Levant. Can you go back a slide? If you look at this, right here, the clinical freedom from TLR, there was really no difference between Lutonix DCB and standard PTA. If you tease down the data, which I know the company's done, and I think it'll be coming out in publication, is that one of the things was that the balloon to artery ratio is incredibly important in terms of delivering the drug. As you know, any DCB that you use is just going to be a vehicle to deliver the drug. So it's very important that we size the DCB very, very carefully, so we have a greater than, we prefer at least a 1-to-1, but if not, a little bit greater than a 1-to-1 ratio in order to go ahead and deliver the drug. You don't want to deliver this balloon at high pressures. You want to deliver the balloon at nominal, so it's incredibly important to size the balloon. So don't get fooled by this standard, this clinically driven TLR slide. You know, the second thing, if you look at just the primary patency by duplex criteria, clearly you have had a 30% improvement over standard PTA. So some may argue, well, if you have a clinically driven TLR that's not different, but yet you have a binary restenosis rate that's different, well, what was the cause for that? Well, the question may be the question of bias. You know, one of the things with the Lutonix trial, which was very well done, was that it was very well, how can you say, the operator was blinded to the result of what was happening. So the primary operator was not the one. I know in our institution, Dr. Wiley was the one who was seeing the patients on follow-up on my patients, and I was the one seeing patients on his follow-up on his patients. So he wasn't aware of what I decided to do, whether to re-intervene on these patients or not. So there's a lot of, I know you can't compare things, but clearly I think this is a very landmark trial that showed that DCB is better. The second thing also we learned is how to do angioplasty. I think we've all gotten away from the art of angioplasty, and I think back in the day when in the coronaries, angioplasty was done much better than we do it now. I think now with the advent of DCB, we're all going to relearn how to do angioplasty. You know, sizing the balloon appropriately, prolonged balloon inflation, gauging our dissections properly, and knowing when to intervene. Go ahead, Bhaskar.
So this is the IMPACT Italian registry, and if you look at the popliteal lesions, you found that that they had very similar patency rates compared to the SFA. The Kaplan-Meier curve you see up on top, the blue line is the SFA and the green line is the popliteal. So next we're going to switch gears, and so the question is, when do you stent? So obviously when you have flow limiting dissections, if you have a contiguous lesion with the SFAs, especially in CTOs, especially when you've used re-entry devices entering into the popliteal segment, significant restenosis, long calcified lesions, and obviously with popliteal aneurysms and perforations, you usually use the covered stent. So question is, if you do have a stent, I guess everybody's already answered it, that they most likely would prefer the Supera stent, and the reason is, it's an interwoven self-expanding nitinol stent. It has 6 pairs of these super elastic nitinol wires, and it forms a helical pattern, a closed cell geometry. Again, they mention radial strength, but actually when you look at some of the models, it actually prevents compressibility, and that's what really helps it, especially when the stent is deployed, and when you look at it, any part of the vessel, it's never straight, and that's what gives it this. And therefore, it pretty much helps with the natural movement of the vessel. So this is a stent which was deployed, and revealing that the anatomy is so well preserved, especially with the flexion and the hinge points. And this is something which just gives you an idea when it's compared to some other regular nitinol self-expanding stents, because of the helical pattern and the way it's woven gives you this benefit. So just to go over the superb clinical trial. So the design, it was a prospective multi-center non-randomized study. The objective data was educated by independent Angiographic and core laboratories. The events were also educated by independent clinical events committee, and the primary effective rates they were looking at was vessel patency at 12 months, which was essentially freedom from restenosis, and they looked at the duplex ultrasound findings of a peak systolic velocity ratio of greater than 2. And essentially what they said was the study met the safety and effectiveness. They had a patency rate approaching almost 86% at 12 months. Primary patency of 90% at nominal deployment, which I'll go over. And then again, the minimal change in clinically indicated target lesion reintervention rate between 12 and 24 months. And again, a significant freedom from restenosis irrespective of the length of the lesion, and they had no stent fractures at 1 year. And the reason they had they're highlighting on the fractures because we've seen that especially at these flexion and hinge points, these stents are highly prone to it. So the primary patency by VIVA, the VIVA means essentially it's the proportion of patients who have their stents patent, and the Kaplan-Meier is just each stent or each patient's stent patency. And clearly you can see with 79% by VIVA, 86% by primary patency, and this is all the way till 36 months, holding on till 83%. And these were some of the baseline characteristics of these patients. You notice that around 25% of them were total occlusions with almost 35% proximal popliteal and distal SFA, the region of concern in our case too right now. And then this is an important slide because it's important to learn how to deploy the stent appropriately and how to prep the vessel appropriately so that you can get effective primary patency rate. So if you stack the stent up a lot and you don't prep it well, you get some amount of primary patency, and they didn't find significant difference. But if you look at the bar graph in the middle, if you prep it appropriately and size the stent 1:1, which Dr. Krishnan was saying, then your primary patency rates are pretty impressive at 90%. But definitely what you don't want to do is, if you elongate the stent, then your primary patency rate definitely drops down quite a bit. And then again, this basically highlights the same thing, freedom from TLR at 1, 2, and 3 years. If you prep it appropriately, your results are excellent. But again, once again, if you elongate it, your results start to really go down. And then this is to show that irrespective of the length of the lesion, as short as 35 millimeters to all the way to 150 millimeters, the patency rates or the non-restenosis rates was pretty impressive with the Supera stent. And finally, with lesions which had significant calcification, you can look at the data all the way to 36 months. This is the freedom from TLR. It was pretty impressive. And 45% in this study had considered severe calcification. Then finally, coming on to this registry, which is the German single center data. There were 470 patients involved, and again they used a PSVR cutoff of 2.4. And here essentially what they found was the primary patency rates once again were impressive, 83% at 1 year and holding up to 73% at 2 years. The secondary patency rates were also impressive. There was no statistical difference between the short and long lesions, and also depending on where you implanted, there was no difference, which is again impressive. And there was no target vessel occlusions at 6 months, and there was only 2 target vessel occlusions at 1 year. And finally, the X-rays done confirmed no stent fractures all the way up to 18 months. And on the right hand side, this is just a comparison with some of the other stent strategies used. Again, you can't compare apples to oranges, but Supera stent with a long lesion did pretty good with 80% primary patency rate. And then this is essentially echoing the same, but using putting them in the primary patency, secondary patency, and freedom from reintervention. If you notice that 52% had moderate to severe calcification, 53% had total occlusions, and once again 60% of the lesions were involved in the distal SFA segment and the proximal popliteal segment. And then finally, again, as you increase the lesion, the primary patency still continued to held on. And finally, this is from the LEPIG registry, where you find that the primary patency rates at 6 and 12 months were at 97 and 86 months respectively, and therefore making this a very, very attractive stent to use in the SFA and popliteal regions which have heavy calcification. Similar results. And then this is the 12-month primary patency rates, comparing it to some of the other stent strategies. And once again, similar, and then seeing that this one lies really high up when you compare it to the lesion length. And then this is just 3 key things which I want to finish off with this, the Supera stent deployment. You have to pre-dilate, make sure you prep the lesion 1:1, then match the stent. Remember, it is non-compressible and does not really have that self-expanding quality as you see with the others. And finally, you need to deploy it very carefully and slowly, ensuring that you have the diamond shaped as highlighted on the right side. And that's it from me, guys. Thank you.
Well, great job there, Bhaskar. Great job. But I just want to focus on 2 points. I'm going to ask Dr. Guja to focus on one. I'm going to ask Dr. Wiley to focus on the other. Dr. Guja, can you go over the technique of a DEB use that has been accepted pretty much in our lab and pretty much in America?
I think we were part of 3 trials actually, right? We were part of 3 trials, and we still part of the ongoing trial. But so normally what we do is for any DCB, you have to pre-do the lesion with whatever lesion length you think it is. But if you think the lesion length is 100, you pre-do the lesion with 80. You have to give 10 and 10 on each sides of the pre-do balloon, enough for the DCB to act. I think the reasoning behind that is that PTA gives dissections, and I think that's the reason, because of the recoil and everything. The amount of patency rates are not great with PTA. But even with DCB, because it's a balloon, it's a semi-compliant balloon, so it still causes dissections, but you still have the drug on it. So you're not worried about the dissections with the DCB. It's acceptable, actually, to take dissections in as long as it's not flow limiting, because over time, because of the drug and everything, the healing is pretty significant.
So just to, I want to make sure the key points are hit. One is you want to pre-dill with 1 millimeter less than the reference vessel diameter. 2 is you want to pre-dill the entire lesion length. That's for the pre-dilatation. For the drug-coated balloon, think about the drug-coated balloon as a vehicle of delivery of the drug. Be 1-to-1 in the size of your balloon to the reference vessel diameter. Number 2 is give, as Dr. Guja said, 10 millimeters, I mean 10 millimeters proximal to the lesion and 10 millimeters distal to the lesion. You want to go ahead and give what we call as a landing zone to cover the area proximal and distal to where you pre-dilled, so you don't have geographic miss. Dr. Wiley, can you comment on Supera stent deployment and how you prep the vessel and why that's important?
Yeah, well, obviously it's important to have a full expansion of the vessel before you even deploy the stent. Dr. Guja clearly explained that you want to undersize the balloon. If you're using a 6.0 Supera stent, you want to use one size less, or a 5.
No, wait, hold on. I just want to make sure that I think you're getting it mixed up here, because the two things is for the Supera, you have to understand that the outer reference diameter of the stent is 6.5. The inner diameter of the stent is 5.5. So therefore, if you decide to deploy on a 6 millimeter vessel, you want to deploy a 5.5 stent. You want to oversize the balloon by 1. So you want to go with a 6. If you're deploying a 5.5 stent, you want to use a 6.0 balloon. If you're deploying a 6.5 stent, you want to use a 7.0 balloon. If you're deploying a 4.5 stent, you want to use a 5.0 balloon. Incredibly important for you to go ahead and dilate the vessel. We are so aggressive with dilatation that the patient will have pain, that the patient will have a lot of stretch of this particular vessel. This will facilitate the deployment of the stent on without elongation of the stent, and you'll be able to land it on a dime the way Dr. Bhaskar is saying. As you can see, the data is incredibly clear that if you are properly deploy the stent 1-to-1 and don't elongate it, then you have clear better patency rates. So that's important. So like I said, Dr. Dangas and Dr. Kapoor, we are learning a lot in terms of how to do proper angioplasty, how to deploy stents better, how to use the drug-coated balloon better, and how even to atherectomize better.
Great.
So
let's go to the case now, so we see what we're going to do in this particular one, although there's very many options that we have, and all of them are great options.
So what do you think, George? I mean, we've made up our mind. I want to know what you think.
Well, I think first of all, we've got to do a little ballooning to open up this vessel. It used to be closed with just a wire across.
Got it.
So we got an approximate diameter of about around 5 to 6, tapering 6 proximally, 5 distally with the IVUS, which was actually very useful for that one.
The groin.
So maybe you want to start with a 5.0 balloon dilation, see where we get.
All right, Vishal, any thoughts?
No, I think that makes perfect. I mean, I don't know if, I'm sure you must have done an atherectomy as well, because we showed it by IVUS that you were almost intraluminal with the calcification and the plaque there.
Yeah.
So, there it goes.
And Dr. Wiley, what do you think?
I think it's appropriate to utilize atherectomy and use the data from the definitive AR.
Okay, so
particularly since you went intraluminal.
Well, I think that the key thing here is the two things with atherectomy. Now, I'm going to ask Dr. Guja to pass the atherectomy device. Pass it, Dr. Guja. So when the atherectomy device goes, I want you to look at the bias. Now, stop there, Dr. Guja. So when you see here, I'm going to mag up to the largest mag here. You see the bias, how the atherectomy device is bowing towards to your, I guess if you're looking at the screen, to the right of the screen.
Yeah, to the right of the screen.
So when it bows to the right of the screen, you see the cutter on top. I'm going to rotate it to the area of danger, what I call, right? So if your device goes in looking like this, okay, that is going to create a very aggressive cut in your vessel. Okay, this is when you perforate a CTO. Okay,
Right.
so when you guys, like, I mean, those of us, I know everybody in this lab is very proficient with ROTA. Those of us who understand ROTA understand the idea of wire bias. So here, right here, it's this is not the wire bias. This is the toggle and the curvature of the vessel that's pushing the atherectomy catheter up against the wall, and you're going to get what we call as a very deep cut. So what we've developed here is actually to do a different type of cut. Dr. Guja is going to pull it back. So the reason why you push the catheter through is that you learn what's happening with the vessel. Okay, and now since we know that's the bias, now we're going to go forward again. Dr. Guja, go forward again. So as we go forward, I'm going to just torque it immediately, let go of the vessel. I'm going to torque it immediately now, and now I'm going to go forward again. Now you can see the bias is a lot less, right? So you can make a medial pass safely, or you can make in this range here, an anterior-posterior pass safely. Go forward. You see, but the problem with the anterior-posterior pass is you see here, it's rotating. So therefore, Dr. Guja is going to have to pinch it, or maybe I'm giving him too much slack here, one or the other, in order to do it. So what I'm going to do here, Dr. Guja, is let's do a medial pass, and then we'll do an anterior-posterior pass, okay? Give a little diarrhea. I don't want to come outside the vessel.
Yeah, if we can recall from the IVUS, indeed the passage was somewhat eccentric. So of course it's difficult to know which side is eccentric, but clearly one passage was more close to the vessel wall than other, and probably in the medial is the plaque mostly. So it's very wise to start cutting from this area.
So I think it's important here, and also it's important not to get crazy. You know, in this era of drug-coated balloon, where you have a drug-coated balloon, you know, the definitive AR data that Dr. Wiley so nicely pointed out. Keep going. No, it's okay. Keep going. You're okay right here.
Twisting a little bit, but not a lot.
Not a lot, exactly. Keep going. A little bit more. A little bit more. A little lower. A little lower. Trust me. A little lower. A little lower. A little lower. Good. Okay. So we're already full. Take it out. So the cutter is already full, which is one of the pains in the neck with these directional atherectomy cutters. But we'll go ahead and empty it, and we'll take a picture to see how it looks. So, you know, what I was beginning to say is that, you know, the definitive AR, which was presented by Tom Zeller in Viva, clearly showed that, you know, in complex lesions, again, it was not by any means, and we presented it last conference that we had here, by any means, it clearly showed that in more complex lesion subset, the combination of atherectomy with drug-coated balloon may be more beneficial than drug-coated balloon alone. And the lesion subsets that Dr. Zeller, again, it was only thought-provoking. It was not powered to show a superiority or even non-inferiority. What it clearly showed as a pilot study was in these lesions with the heavy calcium, long lesions, CTOs, that the postulated theory was because of the possible debulking of the plaque and more ability of the balloon to oppose the vessel wall and deliver the drug, that this could have been the reason why possibly that there's a more sustained patency. So therefore now we're probably going to make two more passes. We're going to make one in the anterior and one in the posterior. Ready? And then we'll be done. And then we got to talk about how you want to size the balloon, George.
Well, I mean, the primary goal here is to avoid a dissection, so I will probably size low, as I said, and we'll probably size 5 to get an initial dilation.
Exactly. I think we dial. How about we pre-deal with a 4, and our treatment balloon will be a 5, because well, George clearly measured it at 5 to 6.
5 to 6. Does it exist in 5.5?
No, unfortunately, no.
Yeah.
So now we're going to go forward. We're going to do one anterior pass and one Karthik. One anterior pass and one posterior pass. I think it's important for everyone at home to look at Dr. Guja's technique. He's incredibly accurate and slow with the way he maneuvers. Matter of fact, he was telling me to torque back because he was guttering. And one of the phenomena that we've all seen who do a lot of atherectomy is this phenomenon of guttering, which is going back to the plane that you cut. So now you see it's very important to give a little diarrhea. Dr. Guja is starting in the medial plane because that's the plane we cut. So that's what we don't want to cut now. So he's going to pull it back a little bit. And what I'm going to do is I'm just going to clock till it faces me. So obviously when it faces me, we don't know if this is anterior or posterior, but I'm going to make sure that I'm going to try to hold it here for him. And he's going to pinch the catheter. Guys, and girls, it's very rudimentary. You know, it's something that you're not happy with. See how it's moving laterally now? I'm going to stop, okay? And what I'm going to do is I'm going to rotate it back here, So this way I don't go to that bias. So it's incredibly important to watch our technique of atherectomy. I don't know what happened here. There you go. Go forward. Our technique of atherectomy is very important in order to prevent complications associated with atherectomy. These are aggressive cutters. These are cutters that are, especially the newer TurboHawk family of cutters, are incredibly aggressive. So it's important to make sure that you follow good technique as you go through this. You notice the care he's taking, that the cutter is not moving. It's staying within the plane that we intended to stay on, whether anterior or posterior.
Yeah, that's great actually. That stopping in the middle and readjusting was a great technique.
George, I think over here we're just going to balloon now since we've done 2 passes. We're going to get a 4060 pre-dill balloon. I think everybody's in agreement with a 4060. And then what we'll do is we'll go with a post-dill, we'll go with a treatment balloon of a 5080 treatment balloon. So here's, we decided to go with a Armada 4060 pre-dill balloon. And again, I think it's important, and I'm going to open up my shutters a little bit so we can see our glow tape, which is important in knowing where our distal landing zone and where our proximal landing zone is. This is incredibly important because at this stage, you don't know, how the distal vessel is going to respond. So what I generally do here, and I know Dr. Wiley does the same, is we pre-dill the balloon and take a picture to see how the vessel is plumped up. Obviously, it's an underfilled vessel, status post to CTO. We have IVUS showing us a very good, vessel diameter. So therefore, we're just going to go ahead and balloon it first, and then we're going to see. Okay, I think this may be a little small. Give me a little die. I mean, not die. Give me the. Yeah, come forward. 1 second. Give me a little die. We'll just see. Just as we thought, it's a little small. Come back a little. Okay. All right, go up here. So we're going to have to balloon this twice, but we'll be careful. And I want to show you guys how to save the cines to know. Go ahead, go to nominal. So this is a 4.0. Go to 8. So this is 8. So we're going to be at 8. She's a little uncomfortable, which we expect.
It's a good length. It's a good length. I will probably go. What's the nominal of this one?
Nominal's 8, George.
Okay, I will probably try to go to 10.
Oh, no. Give me. So you can see here, George, that what we did was we now take a picture, and Ray is going to save it on our second monitor. So this is going to tell us where we were with our balloon, so we don't have geographic miss distally.
Yeah, very important to not move the camera from now on.
Right. Well, we can, even if we move it, that's a very good point, though. But we are going to have to move it back a little bit because what we're going to have to do is come down. So now we're going to come down. Now I'm just going to move it, pull it back a little bit. Give me a little die, Ray, because we know we missed proximally. You'll see it now. See, right there. Go up there, Ray. And it's right by the E on the glow tape or whatever tape that is. 8. Okay, there's another 8 there. Now it's interesting. It's interesting because of in Germany and in Europe, George, with their vast experience in DCBs, they do not pre-dilate. So they go directly with the DCB down. They go directly with the DCB. Our American experience, we definitely do not go directly with the DCB, as you know. We go with obviously a pre-dill balloon followed by a DCB post. Can I have a 50-100, please? This is a 60, right? So give me a 100. 50-100.
So what's their thought process of not pre-dilating with the balloon and then with the DCB directly?
Well, again, Vishal, as you know, it's anecdotal, and from what Dr. Zeller and the people who have done a lot of these are teaching us. What they're saying is that there is no reason to pre-dill, that you have good apposition of the balloon better, unless you have prohibitive calcium or anything like that. In a soft lesion like this, it's probably better not to pre-dill is what they're saying.
Well, if you don't pre-dill, for one, you cannot have a geographic miss.
Yes.
So you don't have to worry about that.
That's a great point.
And the second one, if you do a atherectomy like this one, you prep the balloon, you prep the vessel, one can see already, even a 4.0 balloon got a pretty good result.
Hold on. Actually, Ray,
one
could do it.
have said that, if we do one inflation with a
now,
DCB,
I want to dispel some myths. Can you show the Dr. Ray Lascano's hands here? So you can see here the myths of the balloon are the following, okay? The myths of the balloon is that when Dr. Guja introduces the balloon into the vessel, that all the drug is going to wash off. See, so you have to understand that 70% of the drug is within the folds of the balloon. So therefore, yes, 20% of the drug will wash off, but clearly 70% of the drug is maintained on the balloon. Upon inflation, you're going to lose another 20% of the drug. It's already built into the treatment algorithm for this particular balloon that you're probably going to deliver about 50 to 60% of the drug. The other 20, 25% is going to be washed off at either state. Number two, when you see the balloon comes with a protective covering, you want to go ahead and remove the stylet and you want to go ahead and prep the balloon. You can see what Ray's doing is just kind of rubbing the balloon on top, kind of, we call it the massage of the balloon to help this come off. So then we're going to remove the stylet, and then we're going to remove the balloon. We're going to remove this, taking care not to touch the balloon. Now, if you touch the balloon, is it wrong? No, I don't think it's wrong. I mean, we recommend not to touch the balloon, but when you're senile like me and can't put the wire in, you may have to. So the point is, now that you've introduced the balloon, now Dr. Guja, again, is not going to wet the top of the balloon. What he's going to do is hold the balloon distal to the balloon itself. Ray's going to give him a good rail, and then we're going to wire. He's going to use dry gauze. He's not going to use wet gauze. Because you have to understand the polysorbitol, which is the excipient, is going to be activated when the balloon hits liquid. So therefore, you want to go ahead and try to limit that as much as possible. So Karthik is going to go down now.
So you got to deliver it rather quickly in the vessel.
Okay. Now you have to go to 5. Okay. Now give me a little diarrhea. So now we're going to do a little roadmap.
So you're using a 5080?
Yeah, we're going to make sure that we're not. It's going to be a little long, which I'm okay with. Right. See, we're going to go down to there.
Yeah, that's
there
perfect.
You go. Now we're going to go up really slow. So now remember, the timer goes on now. We try to inflate within 5 minutes of inflating it. But truthfully, as I said, the drug does not wash off till the balloon is in the body. Go slow, guys. So remember, we're oversizing this. I know Dr. Wiley's cringing a little bit, but we're going to go very slow, and we're going to try to expand this. She will have a little discomfort. So, we know we have IVUS sizing telling us it's a 5. So we're going to go slow. Respira con su boca, mama. Respira con su boca. 3. Okay. 4. 6 is nominal. 5, 6.
Looks very good.
5, 6.
Try to stay there.
6. Okay. Respira con su boca. Respira.
Always
Respira.
tend to deflate a little bit. You see how good expansion we get.
Now we're gonna keep it up for 3 minutes, George. Again, there is no real science to this. We feel that a 3-minute balloon inflation is going to help with really getting enough of the drug across. As you know, the paclitaxel is hydrophobic and lipophilic. So therefore, we'll be able to deliver this drug with the help of the excipient across the lesion. Second thing, you can see here clearly we have expanded, we have covered, and we don't have a geographic miss. If you look at our 2 monitors, I don't know if you can see them, I don't know if we can see, you have one monitor that shows the actual balloon inflation on the left, and the other monitor that shows our pre-dilatation. Can you go to those guys? Yes, there you go. So now you can see, you can take my picture off. So now you can see that you clearly don't have a geographic miss, which is incredibly important in terms of the technique of balloon angioplasty in these particular lesions. All right, so we're approximately about a minute and 15 seconds. Elizabeth is managing the discomfort a little bit. Go to half pressure. So I'm going to drop the pressure a little bit now, so to give the patient a little bit of relief. And then we're going to go ahead and take a picture at 3 minutes. Generally, these chronically totally occluded vessels, as you know, George, are very fibrotic. And when you expand them, they clearly have a lot of pain. Dr. Wiley, any comments?
No, I agree.
Dr. Kapoor?
No, I mean, it looks great. It's well expanded, and I'm hoping we'll have an excellent result. So,
well, the only worry I have is distal edge dissection, right? That's the only worry I have right here. I didn't see a pop of any sort. Hopefully here we'll be able to, look pretty good and get away with it. Let's see. I think one of the things that the companies need to do is to start making tapering DCBs, things like that, which hopefully they will do in the future.
So what's your clinical follow-up on these patients once you've...
Dr. Good, you want to comment on that?
So I don't think we have to do any special kind of a follow-up. I mean, it's the same kind of follow-up. I mean, we're not putting a stent in. Because we're not putting the stents in, you can basically do ABI PVRs on this patient. So we routinely do ABI PVRs at 3, 6, 12, and yearly follow-ups. So you can do the same kind of follow-ups unless they clinically have any symptoms, which is a difference. Which is what we normally do. We're not doing anything other than just doing atherectomy and balloon. We're just adding drug-coated balloon to it.
Dr. Wiley, any comments on oral antiplatelet therapy?
No, I think we'll use the standard therapy. We're not leaving any metal behind, so
Down.
we know the data for antiplatelet is still
Just walk it back a little, just give it a little test. So you
good
can
in patients who have peripheral
Go down.
disease. So we'll continue that
pressure
as well.
went down, huh? Okay, walk it back a little bit. Very good.
Wow.
Well, we're not done yet. We're going to walk it out. We'll take a nice picture. You're going to have a funny looking step down, which we've seen in these type of vessels when we go from larger vessel to a smaller vessel. And she may have some stretch pain, as you guys know very well. So we're going to go ahead and take a picture. I think that's groin pain, I think, right?
Yeah.
Yeah, that's groin pain.
Long sitting.
So now we're going to do DSA. So the beauty here is you can see we've still preserved the collaterals, right? So we haven't lost those collaterals, which are so important in making her feel well and making her feel better. So, I think the collaterals helped her claudication to be Rutherford 2 to 3, and obviously, we preserved them. So hopefully that if this God forbid goes down, then you still have the collaterals that are preserved. So like Dr. Wiley said, the oral antiplatelet therapy will be continued for a month. If she has other reasons to be committed dual antiplatelet therapy for a year, we'll go ahead and do that. Otherwise, we'll stop the Plavix at 1 month and we'll continue the aspirin for life. There's still no replacing risk factor modification and good follow-up, as Dr. Gu just said. I think we're pretty much done here, guys. We're just going to do a runoff offline and then we'll be done. We're a little bit over 9:10. So, Dr. Dangus, Dr. Kapoor, I thank you so much for
I think this was a
moderating.
great case. It was a great case, very challenging.
Well,
You can see even with the wire on the side here, you can see how bending it is, and we managed through all the various techniques to preserve this natural bend of the vessel that's only going to be accentuated when this patient walks, and et cetera, et cetera. Any other comment, Vishal?
No, it's a very impressive case with excellent results,
Well,
and
I'd
she's
like-
going to feel great.
I'd like to
Right.
just before Dr. Dangus closes, I want to thank Dr. Dangus for the last year and Dr. Wiley for so much moderating that the both of them have done. Really, from the bottom of my heart, I thank both of you. Dr. Kapoor, thank you so much for stepping in and helping us. Bhaskar, great job. Dr. Guja, and Dr. Ray Lascano, and Ricky and Elizabeth, our team, as well as the wonderful AV folks here. Thanks again for really supporting our program. And we'll see you next year. We've got a great 12 cases lined up for you, and we're just going to make it more exciting with the website's going to get even better. And we'll see you guys all in June. Merry Christmas, or Happy Holidays, and a Happy New Year.
All right, PK. Happy holidays, Happy New Year from us as well. The dates to remember: January 28th, the first webcast of the 2015, and same time of the day, wherever you may be around the world, our 8 o'clock in the morning in New York time. And 17 to 19 of June 2015 is our live webcast, our live case course, I should say, the complex coronary valve and vascular cases here at the premises of Mount Sinai. You can keep your calendars on site so you can come see cases, participate at the lectures, and meet all of us in person. Vishal?
Thank you so much, and we'll see you next year.
All
Happy
right.
holidays.
So long from New York.